Hello, everyone. My name is Kristen Willard, and welcome to the first ever event for We See You. We are the first nonprofit in the United States devoted to chronic urticaria. Again, my name is Kristen Willard. I'm the executive director here at We See You. And I'm also a person who has had urticaria off and on during my entire adult life. So I'll tell you a little bit more about that today as we talk. But let us meet our esteemed speakers. I'm so happy to have them here, and I'll tell you a little bit about them. First, I'll introduce you to Dr. Jonathan Bernstein. He's adjunct professor in the Division of Rheumatology, Allergy, and Immunology at the University of Cincinnati Medical Center and a partner at Advanced Allergy Services and Bernstein Clinical Research Center. He's a past president of the Quad AI and serves on multiple national and international advisory boards. A certified clinical trial investigator, he leads research on chronic urticaria and angioedema, which you will hear more about today. He's published over 500 articles and 5 books. Just hearing that makes us tired, and served as editor-in-chief of the Journal of Asthma. He's received numerous awards, including those from Quad AI and WAO, and has been named a Best Doctor in Cincinnati. He directs multiple centers of excellence related to allergy and immunology, and we welcome you today, Dr. Bernstein. Thank you for being here.
Thank you.
And we also have Dr. Karen Rance. Welcome, Karen.
Thank you.
Dr. Rance is currently the Chief Medical Officer at the Global Allergy and Airways Patient Platform. She has a doctorate in nursing practice and has over 2 decades of experience in clinical care and medical affairs. Previously, she led North American Medical Affairs at ALK Abello and chaired the American College of Allergy, Asthma, and Immunology Corporate Council. A nationally recognized leader in allergy and asthma, Dr. Rance has held leadership roles with the National Association of Pediatric Nurse Practitioners, the NIH Asthma Work Group, and the National Asthma Education Certification Board. She's a frequent speaker at major allergy conferences and has published in leading journals in the field. So we're so honored to have you both here today. Thank you so much. They are also members of We See You's board of directors. So we're very lucky to have them in that capacity too. So let us get started. For many people, this will be your first exposure to We See You. And so we'd love to tell you more about who we are. This slide tells you a little bit about our mission, vision, and values. And these are the things that we hold up as important in the work that we do and the code by which we do our work here at this organization. And so we consider it our charge to empower those of you that are impacted by chronic urticaria. That could be as a person with urticaria, It could be a family member, someone who cares for them. It could also be someone who treats them as a healthcare professional. We want to foster awareness, education, advocacy, and research to improve all of these factors so you can understand more, so we can improve treatment and outcomes for everyone that has been impacted. These values guide our work, and knowing the individuals working with us right now, I can say that this is the case for everyone that I have interacted with at this organization. We want to act with care and empathy. We want to demonstrate compassion to everyone who is impacted by this condition. We consider it a duty to foster strong relationships and make sure that people have open communication with the stakeholders that are involved in their care and in their everydays, frankly, and that they feel that they have a sense of community and that we see you and you have a home. We want this to be a home for people who experience these conditions. Inclusivity is also very important to us. We want you to know that our door is open and we welcome and respect individuals of all backgrounds. And again, you all have a home here. And integrity is the bottom line for us. We do the right thing no matter what that looks like. So you can count on and trust the people here on this call and our other colleagues for that. And our vision and our every hope that we are shooting for is that a world where you control chronic urticaria rather than it controlling you. I know from experience that this is something that can leave you feeling like you've lost hope at times. And what we want to do is take charge of that narrative, right? Take charge of care, of self-management, and the decision-making process being all together as partners in this experience and this world. Now, before we get to our myths, I want to tell you just a little bit about the four pillars here at We See You, and these really are the foundation of all that we do. The first is awareness. So think of this as the top line for everything. We need to make sure that we increase awareness of chronic urticaria. You'll hear us call that CU just as an abbreviation. And that can be anyone in our community. It could be patients, it could be healthcare professionals, it could be policymakers, family members, carers, etc. But we want to make sure that awareness increases so that recognition of chronic urticaria, really meaning diagnosis of this, is not delayed, that patients with CU receive the care and support that they need and that they deserve. And my expertise is in education. We'll move to that next. But we want to be sure that evidence-based educational resources and tools help those affected to understand their symptoms, manage the condition, and feel better equipped to make decisions about your care and your chronic urticaria journey. And when I say evidence-based, that just really means that these are based in science. We are not pulling these out of just personal experience or what someone has said on Facebook. As you can see here, we have esteemed physicians with us who are helping us to understand what that science looks like, from journals, peer-reviewed journals, from their experiences in the field, and of course from guidelines and recommendations that have been published. Next up, let's talk about advocacy. And in this case, we're talking about advocacy as it comes to policy making. So what we want to do in part is to call attention to the challenges of our community. When we do that, and we can demonstrate what those challenges look like, when we can offer solutions to those challenges, we can then help to affect change on a level that then changes things for people across the United States. And as part of this, what we're doing is amplifying the voices of the people who are impacted, because nothing replaces the expertise of a person who has been impacted personally by a condition, and this includes chronic urticaria. We know there are many stories out there. We look forward to hearing yours. And I know two colleagues here can speak to research quite well. We want to support and participate in patient-focused research and innovation. So we want to make sure that this has the patient experience at the center of this, and of course that this is evidence-based. And we want all of this as we move forward toward life-changing solutions for all with CU. So just know, if you're sort of new to this area, that there are people at all times working behind the scenes to make sure that there are things that are new and tried and true and proven. They're making sure that those are coming down the pike for you. So again, I want you to have hope in this moment. So as we move forward and grow as a community, I think that you'll see more offerings in each of these areas, and you'll see how these building blocks all fit together. And I'm excited to show you that, and I know my colleagues are as well. So thank you for being here. Just a couple housekeeping items. If you have questions as we go, please feel free to write them in the chat or the Q&A. And we hope, now we can talk for a very long time, but we hope that we will leave time at the end for Q&A. If not, we may follow up individually. But for now, we're going to start by tackling myths that we see in many places. We see them on the internet. We hear them. I hear them from fellow patients. My colleagues may hear them from patients with whom they interact, and we're going to move to that now. So let me stop sharing. Hello, Dr. Bernstein and Rance. Now it's the three of us on the line. So let's get started. I'm going to start with you, Dr. Bernstein. So I think there may be people here who don't yet know what is urticaria versus chronic urticaria, et cetera. And one of the biggest things I hear, we'll do this sort of a twofold, is chronic urticaria caused by an allergy?
So for urticaria, this refers simply to hives, and hives are where you get welts, you get wheals and redness. These lesions can be localized, they can be diffuse, they can be intermittent, they can occur suddenly and go away and not come back. They can persist, and it's when they persist longer than 6 weeks, we call it chronic. So this is what we mean by chronic. It's an arbitrary cut point, 6 weeks or longer, but it's a consensus recommendation by experts. About 25% of patients might also have specific triggers, and these are typically mechanical or physical triggers like heat or cold or exercise or pressure. Or stroking the skin. When the skin is stroked in a subset of patients, up to 5% of patients with CINDU, which is called chronic inducible urticaria, their skin welts. And so this is a form of physically induced hive. So it's an interesting condition. We never really had much to offer for this condition until the last, I would say, 15 years, 10 to 15 years, when we started getting some better opportunities for drug development, novel therapies that have made a major breakthrough in the management of these patients. Can it be caused by an allergy? Well, what do we mean by an allergy? An allergy is a specific immune response. And as an allergist, we think of 4 types. And I'm not going to go through that, but one is the type where you think about seasonal allergies, where you actually are exposed to pollen, and people have had previous exposure. They develop allergic antibodies called immunoglobulin E, and that is attached to allergic cells in our body called mast cells. And upon re-exposure, let's say the subsequent season, that can the pollen is in the air, it can activate these antibodies and cause mast cells, which are the allergic cells that release histamine to be activated and cause symptoms. We don't see this as a mechanism for chronic urticaria. In acute urticaria, certainly people can get acute hives from eating a food if they are allergic to a food, or sometimes when they're out exercising and have really severe allergic reactions, they might have some hives and breathing problems. That's not very common, but it can happen. But what we're talking about is chronic, where it's lasting, it's persistent, it's lasting longer than 6 weeks. And it's not triggered by a food or a specific drug or some other known stimulus. In fact, over 95% of cases, we just don't identify an underlying trigger for hives in these individuals.
Thank you so much. And I have to say, that was one of the most difficult things for me to come to terms with as a patient. I sought a cause for this for a very long time. We're so used to having control over certain aspects of our health, I guess. I thought if I cut out certain detergents or if I changed the kinds of towels I was using, that maybe this wouldn't happen to me anymore. And it just wasn't the case, and we never did find out what caused it. It was comforting for me to learn that that was the case for most people. And I know that sounds strange, but it was a comfort to know that I was not the oddball, I guess.
Well, we do know that physical factors will induce hives in those patients who have inducible hives. So
Oh, yes.
like cold or heat or exercise. But what's turning on these mast cells, and this is where interesting advancements in understanding that there's many receptors on mast cells, and they can be activated by different stimuli. So this is where we're learning more about how mast cells are activated and how they play a role in different types of hives. Because not all hives are the same; they're very different for different individuals.
Thank you. That's a great way to kick us off. I appreciate it. Let's turn to Dr. Rance. And here is another one that I have heard often and thought myself, frankly. So, what about this myth? Food triggers CU.
Well, I think that is a great topic just for us to briefly discuss. So it is understandable to wonder about foods. It's also very natural to look for a cause when symptoms are so disruptive as they are. You articulated very well, Kristen, and that's why we're so great. It's great for us to have you as our executive director. Your journey and how you really, kept looking and looking. But to dovetail on what Dr. Bernstein said, that the predominant, certainly the predominant number of cases are not contributed by food. Although food can cause hives, we see a true food allergy as causing more immediate and reproducible symptoms. So Dr. Bernstein also touched on, other triggers which would need to be considered, including stress, temperature changes, illness, viruses, medications, and the like. So I think all of this really points to the importance of accurate diagnosis. And I think it is so very important for those listening, perhaps haven't yet started their diagnostic journey. And so we hope to give you information that will really empower you today to, reach out and say, okay, I'm ready to get a diagnosis. Because I'm sure, Kristen, you can attest to that, though the end result for you personally was that there was no identifiable trigger or was idiopathic, the journey of ruling out things helped reduce the stress, right? Because when individuals, when patients carry unnecessary and inaccurate diagnosis, it really impedes on their quality of life. It adds burden in and of itself. So, I think when we look at, this starting the diagnostic journey that that we're discussing here, the listener of this webinar, really are in the most important position. You're driving the car initially when you have that encounter, in as much that your medical history that you can bring in, let's say that Dr. Bernstein has a patient tomorrow, right? If that new patient can come in with as much medical history, it makes what he does, that much sharper, more defined, et cetera, and sometimes can actually expedite that diagnostic journey. So just want to encourage everyone, for those of you who've not yet sought an allergist, that when you do, be sure to take, a note on your phone, or you're taking pictures of things, asking family recall, because thinking 6 weeks back, I mean, we often can't remember what we ate for breakfast this morning. So, thinking 6 weeks back, we often have to encompass the people we live with, perhaps coworkers, something along that line.
I think that's a really helpful way to think about it too, is that the more information is sort of the better until you really get things narrowed down. I found it very empowering to have something that I could name, just that I could point to, because before it was, I really didn't know, even though this is unpredictable, I didn't know what it was at all.
Right.
Was this an acute episode? Was I causing them? Like I said, my Sindu, which again I'll refer to later, that was a little bit easier for me to wrap my head around because I could see sort of cause and effect if I was writing on my skin, and I got a hive in the shape of what I had written. That was much clearer to me, but the others not so much. So I think that's helpful. That's a very helpful way to frame it. Okay, next up, let's move to antihistamines. So I'll post this one to Dr. Bernstein. What about this one? Antihistamines are the only treatment for chronic urticaria.
Well, antihistamines refer to histamine type 1 receptor blockers. There's, antihistamines is really a general term, but it just means that they block histamine, and they're specifically targeting receptors on blood vessels. And so they are the first line treatment for urticaria, and in all guidelines, H1 antihistamines, preferably second generation non-sedating antihistamines, are considered first line treatment. Not everybody responds to the dose of once a day antihistamines, and so the guidelines actually recommend that you can increase the dose up to 4 times the recommended FDA dose safely. So this is a consensus recommendation, but that again only works maybe in up to 45% of patients, depending on the study, sometimes only 40% of patients. So where do we go from there? And we now have other therapies. Of course, we used to use a lot of treatments before we started having better defined therapies because we had to help patients. And so we used a lot of drugs off label, but now we have specific therapies that are approved for urticaria. And this has made a major advancement in our management. We use other therapies, but there's a little difference in opinion between certain guidelines, whether we should use medicines like H2 antihistamines. These block histamine type 2 receptors and leukotriene receptors, which block leukotriene receptors. And these are all released from, again, histamines released from mast cells, as are leukotriene. So the evidence is not as strong. So I think when you talked earlier about guidelines, we try to synthesize or extract all the information from the literature and put it together to create these algorithms, these treatment recommendations. But more recently, we have had some newer therapies, and maybe Karen can elaborate on that.
Absolutely. There's a lot of research ongoing looking at biologics and products that we're seeing the expansion of indications. So very exciting frontier that awaits us.
Yeah, and so I joined that enthusiasm that you have. I think the newer therapies are things like omalizumab, which have been around actually now since 2014. It's a drug that's been around much longer because it was originally approved as asthma, but it's been shown to be very effective in the treatment of different types of hives. And now we have on the cusp of several newer therapies that are currently being investigated that might be approved soon, and that's going to create an even more interesting opportunity to help manage some of these more difficult to treat patients with chronic urticaria.
Ask a quick follow-up question about the antihistamines. I see this a lot online, that people are using sedating antihistamines a large amount of the time and might just be choosing them themselves. Is that something that we're still using according to guidelines?
They're not recommended in guidelines. In fact, they're discouraged because of their effects on sedation. They cross the blood-brain barrier, can cause cognitive problems, especially in older people, and so they're not recommended. They have very good antihistaminic effects, equal to the second generation newer antihistamines, and these are also over the counter, or you can get them through a prescription. But most of these newer second generation antihistamines do not cross the blood-brain barrier. They don't go into, they don't affect the central nervous system. Some have mild effects, but most of them are very well tolerated. And there's now several of these that are available in the United States for use over the counter as well as prescription. But this is what's recommended, second generation. What you're referring to as first generation, and like diphenhydramine, which is very sedating and not recommended. We still use diphenhydramine for certain indications, but not for chronic hives.
That's very helpful, because I do see an awful lot of that online and social platforms, that people are still using that because this is what we all grew up with, associating with treating an allergy, right? So, or
and sometimes they may not be effective, but they just help them go to sleep, so they can put up with the itching and the swelling, which bothers them, so they can at least sleep and get some rest, because they are very debilitating, which I think really leads to the next question that is about, it's just a skin problem. Maybe Karen wants to speak about the impact that that hives has on people more than just the overt manifestations of hives and
Absolutely. And I think it is well recognized that chronic urticaria is more than skin deep. So certainly it involves physical manifestations, much like we have already discussed. But it's also important to recognize that it will often affect the mental well-being of the patient. And debilitating is a good word, Dr. Bernstein, that these patients are often rightfully so, quite distressed. And so we can see how the emotional aspect could confound the diagnosis. And what we do know is that outside of the symptoms that we most readily think of, the itching, the pain, the visible hives, things such as tiredness, sleep disturbance, achy muscles, achy joints, anxiety, even depression are well recognized with patients who have chronic urticaria. So I think the first thing for us to do is just to say, hey, it's okay to have some emotionals up and down with this condition. And that is something certainly to discuss with your doctor, your nurse practitioner, your physician assistant, who's ever following you, and to get some ideas. Part of our mission here, as Kristen so eloquently stated at the beginning, is really to provide resources that you can help support. We've mentioned several times how stress can be a mitigating factor for chronic urticaria in some patients. Well, you can see that if you've got stress just because of the disease, was the initial stress related to the job? I mean, it just gets quite murky. So I think what we can do is certainly advocate for emotional health and recognition that it's okay to be anxious about this. Talk about it. If you perhaps a counselor, you'll find it interesting is a very popular counseling approach is called cognitive behavioral therapy, CBT. It's big in the literature. It's quite mainstream as far as its availability. But this is one approach that counselors can use, psychologists can use, that has shown medical evidence, that patients with skin-related anxiety have improved outcomes. So you don't need to suffer in silence is really what I'm getting at. So
right.
yes.
So I use CBT for different things, but I think the best treatment for hives is make sure they get rid of them, just so they don't come back. And that really improves their quality of life. And as you know, in all of our clinical trials, we always measure a secondary endpoint, quality of life. And it's very clear that the quality of life, which has effects on work, on school, on leisure activities, is significantly impaired. And when you treat them with different combinations of therapy, this quality of life significantly improves. In fact, I want to be clear that hives is not a psychiatric illness. It's a real problem, but it has secondary effects on individuals' well-being. So, and if you have a difficult case and it's not responsive just to antihistamines, and you certainly need to see a specialist like an allergist or a dermatologist who has knowledge and experience with the treatment of hives, so they can get you better controlled quickly and minimize this impairment.
Yes, and I think those are all excellent points. And any management plan, any treatment plan, of course, the priority are medically managing the symptoms. That alone will help the emotional well-being. But as we discussed, the other aspects are important to recognize, right? So, Kristen, I have a question for you. Certainly, in your patient journey, often there's a myth that chronic urticaria lasts forever, for a lifetime. So could you maybe share a bit about your experience and, just reflect on that myth?
Sure, absolutely. One of the things I'm just going to say before I turn to that, because it really struck me when you both said this is not a psychiatric illness. I will say oftentimes as patients with this condition, hives in general, we are often told that if we just calm down, if we just, if we aren't so anxious, this will not happen to us, right? If we just stop all the stress in our lives. And it does comes across, this is very mainstream conversation that people have, not just healthcare professionals, right? It's the general public that has sort of adopted this. So hearing this from you is so freeing and so validating to me because this is not what happened to me or to many of the, other people. And it's just very nice to hear that. Um, my urticaria started when I was in my 20s. I'm 51 right now. And every decade I had an acute or more than one acute bout of hives, where originally triggers for me were things like detergents, or I have a tendency to use lotions that smell fantastic but are terrible for me personally. And then I got into my 40s and they became chronic. And this was unlike anything I had ever experienced before. This really took over my entire life. I could not work well. I could not drive my car. I couldn't take care of my pets. Frankly, I couldn't bathe easily or get clothed because it just was so excruciating to have anything touching my skin. It was terrible. Now, in my case, I was, I didn't, I went to the level that Dr. Bernstein was talking about before of antihistamines and other medications, and that did not control it. And ultimately, it was through a biologic that mine were brought under control after 6 months. Now, in my case, I can say that I'm lucky that right now I do not have them, so that I can say I'm sort of living proof and hope that these do not always last for life. I am always cautious, and you can tell me what you think of this. I'm always cautious because I never know that they're fully gone. Given my experience in the past, when will these old friends of mine, so I use that term quite loosely, when will these old friends of mine make themselves known again, right? I do live like that, but I certainly do not live with it every day. And I feel very lucky, and I hope that that provides some hope. So, what are your thoughts on that, the two of you?
Well, first of all, hives, typically the general thought is they last anywhere from 1 to 5 years, and they can go into remission spontaneously. This is one reason why when we treat patients and we get them completely controlled, and we use different patient-reported outcome measures to assess that using something called the Urticaria Control Test, which is a standardized, simple questionnaire that tells patients can tell their clinician, their physician or nurse practitioner that they're well controlled. Or there's in clinical studies more than anything, we use something called the Urticaria Activity Score, but it's the same concept. So we use this, and when patients are completely controlled, there's no hives, there's no itch, there's no impairment, and this is on medication. So we treat them. How long do we treat them? Well, there's a variable response. Maybe some people say 3 to 6 months, up to 6 months, where there's no hives. And then do we step down? Because like everything else, there's a beginning and there's an end. And so we do try to step down after, let's say, 6 months to see if hives reappear. And in some patients, they do. And others, patients can come off. Now, in those situations, there may be a situation where the hives come back. And it may be over several months or several weeks or months, depending on the treatment that they were taking. But sometimes it doesn't come back. So it is variable. Right now, we don't have any good markers for knowing who we can drive into remission or cure the hives. But it is variable. In your case, I think when you have an inducible component like dermatographism, which is what you're referring to, those are more persistent and they can last much longer and they don't go away as quickly. And I think one of the important points you mentioned is you didn't like putting stuff on your skin, but once you control dermatographia with medication, moisturizing is extremely important, because if you itch, you scratch, and if you scratch, you welt, and if you welt, you itch, and if you itch, you welt. You scratch, and so it's an itch scratch cycle. When it's crazy, it just keeps going and going and going. So you got to moisturize as well, and we recommend products that have very few ingredients, that are very easy on the skin, nothing elaborate, like you mentioned, perfumes and things of that nature. But that being said, it is an important component, because we found in some studies that barrier proteins are affected in hives. And so disruption, maybe it's due to the scratching, the trauma, but it could also be a lot of the skin diseases we take care of actually have barrier protein dysfunction or disruption. So I think that it's an interesting disease. We're learning more and more. And I think, but it doesn't always behave the same. Some people it's more persistent, other people it can go into remission.
Kristen, I think another point that you brought up that is deserves probably a little emphasis, bold font, is that you're not living in fear, right? So you're living your life, but with a healthy respect, what we would call anticipatory guidance, right? You're looking, at the future, like, okay, if it happens, if the symptoms do return, I've got a plan, I've got to go to, etc. So, the priority is medical management, and then certainly take care of your well-being. And then when you do have the resolution, not living in fear, but being mindful.
That's just a perfect way to say it. A healthy respect. That is exactly what I feel. And I would have been more dismissive in my younger decades. I will say that, oh, it was just this, or I used a different detergent. And now when these come to my doorstep, immediately, I know I have a kit of sort of a survival kit with me, so I can start antihistamines if I need to right away. I know exactly what to use. And so that's exactly how I treat it. Hopefully, no time again soon, but um, let's move on. And I'm going to ask this question of both of you this time. And this I see all over the place. And we mentioned this a little bit more, but I'd like to hear sort of what we're doing along these lines and what are our goals if we can't cure CU. But so that's the myth itself. Can it be cured? Will we ever cure it?
Well, I think that we're getting to the point where we understand the major effector cell, the cell that's involved, is mast cells, to also an extent basophils, which are blood cells in our bloodstream, but mast cells are tissue-based cells. And we know a lot about the different types of cells, and they're not all the same. They have different chemicals inside them, one called tryptase, chymase, tryptase. They look different. Some are in the skin, some are in mucosal surfaces, so they're different. And they have a whole array of receptors on their cell surface. And there are some receptors that when you target them and you block them, you can actually kill the mast cell, and you can typically get rid of them. So we're at the point where we know how to get rid of mast cells. And the question is, will that cure hives? Most of the treatments we have now control hives. They get rid of them or improve them significantly, but they don't cure them, in that when you stop, in most studies, the hives will come back in many of these patients over time. Again, let's not confuse that with going into remission. And that's not necessarily a cure. That's more of the natural progression of this condition, that it does, come and go over variable periods of time. But so I think that we're learning more about the pathogenesis of hives, and then therefore we can target specific receptors that may actually turn off mast cells and be potentially curative, turn them off or reduce their numbers significantly. So this is what we're looking toward to do. Of course, every time we develop these treatments, we have to make sure that the safety and the efficacy is better than the side effects. And so that's always something we keep in mind.
Yeah. Yes, and that gives us all a lot of hope, Dr. Bernstein. I think you framed that very well. And the only thing I'll add on to there is that certainly where we see ourselves now versus 10 to 15 years ago, as a medical research and patient care, advocates in this arena, that we have a lot more, we're much closer, right? So the advancements are significant and they are exciting. So it's a good time.
The role of the clinician is extremely important because if you don't characterize your patient with hives when they come into the office, if you just treat them all the same, and here it takes antihistamines and call me if they don't get better, you probably don't have a very good chance of really helping that patient long term. Of course, there will be a subset will respond to antihistamines and you'll never see them again. But the ones, though, that aren't responsive, they may have more complex, more difficult to treat hives. And they need to be better characterized. And we are starting to get to, because of the development of biologics, as Karen mentioned earlier, we now actually have some biomarkers that can make certain predictions. They're not ready necessarily to incorporate into guidelines, but they are useful tools for helping us better characterize patients. And so I think that that's what we refer to as phenotyping, characterizing patients to correlate with the underlying mechanism associated with hives in each of these individuals. And we know that, for instance, up to 50% of patients with chronic urticaria, chronic hives lasting longer than 6 weeks, might have autoimmunity. They might make antibodies against certain receptors on their mast cells. And these patients tend to be more challenging. And this is why we are developing these novel therapies that target different pathways that can treat these more difficult patients.
That's fascinating. That term is fascinating, and I must follow up on that. But before we move on, I do want to ask you if we move toward turning off mast cells, are there other conditions that would help us to control that people with urticaria might also experience?
Well, certainly it can help patients, up to, a significant percentage, up to a third of patients with urticaria might have a condition called angioedema, which is soft tissue swelling. And again, we think about urticaria as affecting the epidermis, but when you get into the deeper dermis, that deeper into the skin, then there can be swelling, because what happens is blood vessels dilate, the cells lining the blood vessels separate, and fluid escapes, and it causes edema or swelling. And so angioedema is actually a sign of more severe hives and sometimes more difficult to treat hives. And a significant percentage of patients have this in association with hives. So certainly that could be a benefit. There's other conditions where mast cells play a prominent role, where these therapies can be helpful. And, it could be any number of diseases, because mast cells are really ubiquitous and involved in a lot of different clinical conditions. We already know, for instance, in some of the newer biologics that have been developed and that might be approved in the future. Well, first of all, omalizumab, which is approved and already approved for asthma before it was approved for hives. So it was working in asthma, and it may, in part through working through mast cells. The same can be said of another therapy called dupilumab, which is also approved for asthma and other disorders where mast cells play a role. And so I think that you're spot on when you talk about other conditions, other comorbid conditions associated with chronic urticaria, and how these therapies could be also helpful for these conditions. And so we'll learn more once if and when these drugs are approved, and we'll have some real-time experience in the clinic on using these therapies.
Forward to that. Now, for me, the angioedema was not the worst part of my hives, but I definitely did have it. And the only way I could explain it to someone was it sort of felt as if my skin could not contain my body. It was so swollen and hard and painful. And for me, it was my hands and my feet the most. But I have learned from many of you that in many people it's in their face, yes, and in different places that it impacts them. Can you just tell us a little bit more about that? Because I know many people will hear themselves in what you're about to say, I think.
Yeah, most of the time we see swelling, it's lips and face, it's above the neck in chronic urticaria. But what the problem is like when you have severe hives at the site, and if it's so severe, like you said, it's affecting the deeper dermis, you can feel like your extremities are swollen as well. There are other types of conditions. Some patients present with isolated angioedema. They only have swelling and they don't have any hives. And so that's a whole different differential in terms of understanding what might be causing that. It could be a similar pathway to hives, but there are other conditions associated with swelling that can, be more likely affecting extremities. But you're entirely correct. I think it's very heterogeneous. Everyone has different experiences, but again, a lot more times we see tongue and lip swelling and facial swelling, but that's not 100%.
Good for people to know, I think, too, because that is something that's very noticeable, right?
Mhm.
And that's something I think a lot of people I have read online, they're panicking because this is what you really associate anytime around the mouth, or your throat. Of course, there's panic related to that versus hives that may have on your arms or something along those lines. But I think that's important that people know what this is. Your doctors will know what that is in order to help you. I think
And
that's important.
fortunately, with hives and even angioedema, we do not see asphyxiation, throat swelling per se. It's a sensation that people are concerned about. And sometimes the tongue can get big and sometimes it might block the airway, but we don't see the swelling in the throat per se with urticaria and the type of urticaria angioedema that we see. There are conditions though where that can happen, and that really is a sign. If you start experiencing that, even if you're not sure, you should still talk to your treating physician or nurse practitioner, whoever you're seeing, to really let them know these are the symptoms you're experiencing, so they can verify what is and what is not going on.
Mm-hmm. Very
Yes.
important.
Please seek care if you have any questions, right? This is not the time to figure out if the internet can help you. Make sure that you receive care to help from a professional who can help you to determine, excuse me. Okay, I just want to encourage people as we are nearing closer to the end, if they have any questions, to type those in the chat or the Q&A, and we'll get to those after the next questions. So here's one that I think is so interesting, and many people do not know the answer to this one. How about this one? CU affects only adults. Is that true?
It is not. Now, certainly it affects adults and more so, but it can affect children. If you look at the prevalence factors, depending on the source, that you're getting your information from, roughly it can be 1 in 100 for adults and 1 in 300 as far as allergic individuals for chronic urticaria. So we do see a difference there. The predominant presentation, it is adults more so than children, and females more so than males. So females specifically, 20s, 30s, 40s are most often affected. But we do want to, make sure we're cognizant of that it can affect the age spectrum as a whole.
So up to like 1%, it may be up to 1, max up to 5% of the total population might experience chronic urticaria. And then of that, a much smaller percentage of children have been identified, but children are more apt to have acute hives, and a lot of times they'll have from viral infections and things of that. When they actually are more persistent, then we do need to look for other underlying causes, because there are some chronic conditions in children that can present as persistent hives. But that being said, we can see just run-of-the-mill chronic spontaneous urticaria in the pediatric group, and we treat them the same. Similarly, again, some medicines are not approved at young ages, but the H1 antihistamines are, as is omalizumab. So we can, use this now in younger individuals as well. So I think that, we have to be cognizant of how this presents, and it's a different population, so a different what we call differential diagnosis, things to consider. One of the things we didn't talk about was mimickers of urticaria, and there's a lot of conditions that mimic urticaria because one of the characteristics of hives is that they come and go. They're evanescent. And a lot of times people might have persistent lesions on their skin or a rash that's itchy that they think are hives. So this is the hives, they appear in one place, they go away, but then they come back in another place, they spread. They can be small, they can be large, they can coalesce, they can become giant hives. So they have they're very different in their appearances. So it's important to know this heterogeneity, these differences that exist in both children and adults.
This actually leads us to one of our questions here. And one of the questions that we've received is, I'm a person of color. Will my hives look different than someone with lighter skin?
Well, sometimes they can be more difficult to see, but it's clear in patients of color. You can see the redness and the welts and so forth. Of course, they're not going to be as bright necessarily, but I've seen many patients with all skin tones, and it's not hard to find them when they're there, and patients can clearly point them out. So it's and they can, but you really yeah, they'll look a little different, but they all have the same features. Everything's very similar, and as is response to treatments and the same algorithms. So there's not a lot of differences other than they may appear more subtle sometimes, but they're easy to identify. Very similar.
So this should not be an extra challenge for a healthcare professional who's treating a person of color.
And you have to listen to patients. I find that the biggest thing is to listen to people because they know more about their body. A lot of times patients are just kind of dismissed, especially when they present and say they have had hives, but they're not there. Well, you don't have them now. Yeah, but I have them tonight.
I don't see anything.
Yeah, so you really got to listen to your patients, and the people they don't want to sit there in your office. They want to be able to go about their lives. They're there for a reason, and so this is really the number one lesson for any patient who presents to your office. Listen to them. They know they're giving you good information.
Yes, I couldn't agree with that more. I do think that is paramount. And, too, as we discussed, empowering, those listening to this webinar, the treatment decision is certainly one that should be shared. And your best allergists and specialists will, they have that, they do that naturally. But if for some reason you feel as though you're not heard, don't stop there because it is so important. And because the diagnostic journey, much like Kristen referred to earlier, the medical management and the recognition that sometimes chronic urticaria is more than just skin deep is real.
Yes, please do not suffer in silence. I think that's one of my takeaways from today. There's no need to do that. And it's almost impossible for most people who have a similar experience to mine. Okay, we have another question. I'd like to hear your thoughts on if chronic spontaneous urticaria could have a connection to other autoimmune diseases. So things like rheumatoid arthritis, lupus, and other conditions.
Well, you can see hives with any condition, but it's not a common presenting symptom. So when we see patients with chronic urticaria, we don't go ahead and order all of these autoantibody tests because they're not typically associated with that. The minimal testing that's recommended in chronic hives is a complete blood count with differential, typically a C-reactive protein, sometimes a sedimentation rate, which are markers of inflammation, and something called a thyroid peroxidase test, or even a thyroid test if they haven't had it, because there is high association with thyroid. But unless there's something in the clinical history to suggest autoimmunity or the nature of the hives, because sometimes hives are not evanescent, sometimes they're persistent. or sometimes they look different. They're violaceous, and in those situations, there is something called urticaria vasculitis, which is seen in about 0.1% of cases of chronic hives, and it's diagnosed by skin biopsy, and it is associated with other sometimes autoimmune conditions as well. Recognize, we talked earlier, that spontaneous hives, chronic spontaneous hives, is considered an autoimmune disease in up to 50% of patients, and but not to the extent where we're talking about lupus or rheumatoid arthritis. It's a different type of autoantibody targeting Ig, high affinity Ig receptors on mast cells. So yeah, it's something that people are often asking about. If they don't have a clinical history or clinical symptoms to suggest it, it's not recommended to go and do a whole workup for that. But if there are clinical signs and symptoms that are concerning, then you should do additional testing.
Thank you. Now we have somebody writing in about their personal experience. It says, I'm 40 now. My urticaria started in 2017. They went away after a year, then came back around pandemic times, and then they went away again. But they are back again, they say. So what they're asking about is if they can take multiple antihistamines in the morning.
Well, we would recommend that you take medications according to guidelines, and not just to take things as needed or a little here and a little there. So again, if it's not responsive to one daily dose of a H1 histamine type 1 receptor antihistamine, then we recommend increasing the dose up to 4 times. However, I would recommend that you really do work in conjunction with someone who knows how to treat hives and not treat yourself, because it'll probably result in this continuous cyclic response of them coming and going, and that can be very disruptive to your life. So I think that if you get in under the care of someone who has experience treating hives, they can get you on a regimen that you can easily adhere to and tolerate, and keep those hives from coming back, and hopefully go into remission once and for all.
That would be my hope. I hope this for that person for sure. I cannot believe it, but it's already 3 minutes before the hour. What I will do just in closing is just ask if each of you could take a minute and tell us 1 or 2 takeaways, given all that we've discussed, that you'd like people on the line to take away from the conversation today. Let's start with you, Dr. Rance.
Well, I would say we've touched on several of them. Certainly not living in fear. Hopefully you conveyed that there are treatments. There is a great deal of advancement ongoing in our field, and there are specialists to connect with, engage with, and have them really discuss and manage and treat your hives. I do want to, another thought comes to mind is that if you are seeing or you meet a physician or nurse practitioner or who's ever PA that's taking care of you, if they are not aware of the current advancements in the field, then I would really consider seeking someone out, and so that is aware, because there's so much excitement around the treatments that Kristen and others can attest to, that simply weren't here 20 years ago. So and then I hope that this is not only educational but empowering to those who've listened in today.
Thank you so much, Dr. Rance. That's wonderful. How about you, Dr. Bernstein, in closing?
Well, first of all, hives are a prevalent condition. They are debilitating in that they do cause a lot of impairment in quality of life. They cause and they can be miserable when you're itching and scratching all day long. They're very different across the board. People have some different types of hives. They look different, but they're treatable. Most of them are very treatable. There are subsets of patients that are more challenging to treat. these tend to be people with inducible hives or with autoimmune characteristics, as we talked about. And that really requires a specialist who has a firm understanding of how to treat this condition. This is not something that people who see one case here, one case there are going to really be able to get their arms around. So I do recommend seeking out experts in the area if you do have more difficult to treat hives. But I also want to say they're not life-threatening, and that people do not die from hives. That these have generally good prognosis if they're managed properly. So that's the good news. And just make sure that you have a clinician who really is capable of treating your hives. Thank you.
I very much appreciate that, because my takeaway today is really that I hope people can feel hope. You can very often feel as if there is nothing that can help you, and maybe you just have not found the right thing yet. So please do not give up. There are options now, and it's important that you get to the right people who can help you. So I want to say thank you. Thank you to our speakers. I so appreciate it, Doctors Rance and Bernstein. Thank you to all of you here. I've also included, you can see all of us here on the screen. Also, thank you to Tanya Winters, who serves as the chair of our board. And we so appreciate you being here. Please stay tuned for all that's coming down the pike from We See You. This recording will be up on our YouTube page. I will also be sending this out via our upcoming newsletter and other emails that I will send to you. Please also stay tuned to our social media for awareness, education, advocacy, and research projects. We have one very exciting project coming up soon, and that is a chat bot to answer all of your frequently asked questions about chronic urticaria. So thank you so much for being a part of this community, and we wish you a wonderful rest of your day. Thanks, everyone.